So good morning. My name is Justin Annis, and I'm director of Stanford's Hereditary Neuroendocrine Tumor Program. And today I have the honor of sharing with you an update on pheochromocytoma and paraganglioma and current approaches to treating metastatic disease. I think it's important to start with a background of what paragangliomas and pheochromocytomas are. These are complicated words that are often confusing to patients as well as physicians. So a pheochromocytoma, sometimes they're now being called an intraadrenal paraganglioma, are tumors of the adrenal medulla. These are cells that are called chromophene cells because of the way they stain on histology. And generally, they produce adrenaline or noradrenaline. And as I said, this is showing the location of the tumor within the adrenal medulla. Paragangliomas are similar tumors of the same cell type, but they're located outside the adrenal medulla. As you can see in this image, they're located near these green circles, which are called ganglia. And the tumors are paraganglia, meaning next to these ganglia. Ganglia are nerves, or the cells, the nuclei of nerves. And these paragangliomas typically form right next to these nerve cells. And they can form anywhere in the body. When they occur in the abdomen or the pelvis, they are most frequently norepinephrine or epinephrine producing or metanephrine producing. And as you go up closer to the head and neck, they're less likely to be hormones secreting. In the head and neck, they're typically parasympathetic rather than sympathetic paragangliomas, so they don't produce or rarely produce the metanephrines. And again, they're located near the nerves collections, often the cranial nerves, and that's why doing surgery on these particular tumors can be quite challenging. And these are sometimes separately referred to as head and neck paraganglioma because of this different biology. And I'd like to take a moment to say that we know relatively little about the biology of paragangliomas and these neuroendocrine tumors. And my laboratory is focused on studying the biology of these tumors. Here, I'm showing a mouse that we've engineered in order to highlight these cells. And we've engineered them to make a green fluorescent protein in these cells of the paraganglia. Specifically, one that occurs in the abdomen is called the organ of Zucker-Kandel, and you can see it here. If the cells are in the adrenal medulla, these are the ones that give rise to pheochromocytoma, and in the carotid body, this gives rise to head and neck tumors. So we have a long way to go in terms of understanding the biology of these tumors, but I think these images help you to understand where these tumors grow and where the cells are located. Another fundamental point that I think has gone relatively unrecognized is that the paraganglia cells, while they're present in the newborn and serve an important role during embryogenesis and fetal development, typically they begin to regress as people age and are virtually gone by the age of 20 unless something has happened in order to make these cells last. So here is actually an image from a mouse that's a little bit older, and you can see that these paraganglia cells are almost gone. And what I want to again highlight is that here in red, what I'm highlighting is the ganglia. And these paraganglia cells are next to the ganglia, and that's where they get their name from. I think this is quite confusing terminology, but perhaps it's helpful to at least see and understand where these cells come from. Okay, what do paragangliomas look like? I'm showing MRIs of a head and neck or carotid body tumor here on the left. This is a paraganglioma of the chest. As you can see, it occurs in the back near the spine. And then this is a paraganglioma of the abdomen. And these are relatively easily or well visualized in MRI, and so that's why this is a useful imaging modality to use to find these tumors. Another important point that I'll make is that if you look at them, they look fairly well circumscribed. That means they look circular and closed in. This is what's led them to historically be viewed as benign tumors. However, it's important to recognize that we no longer consider any paraganglioma or pheochromocytoma to be benign or inherently benign. All of these cells have the potential to spread. And based upon histology, we can't tell which ones are likely or are going to spread. Here, I'd like to highlight the histology of pheochromocytomas and paragangliomas so that you get a view of what they look like at the cellular level. This is a typical H&E or hematoxylin eosin stain. And what you can see is that the tumor cells occur in these little nests, these somewhat ball-like structure called zelbellins. And another important point to note about them is that these cells generally look all the same. This is somewhat, we would call it monotonous, or sometimes historically called benign. But again, these tumors are not benign. Again, the other thing you'll notice is that there's lots of red or red blood cells. These are very highly vascular tumors. This is what it makes biopsy relatively less appealing, in addition to the fact that they can produce or release lots of adrenaline and hormones. But it was hopeful that because they're so vascular that we might be able to target that with medicines, as I'll talk about in later slides. A characteristic feature of these neuroendocrine cells is an expression of a marker called chromogranin A. You can see that they stain very strong for chromogranin A. Synaptophysin is also a neuroendocrine marker. So neuroendocrine or chromaffin paragangliomas will stain positive for both of these markers. A third marker that's important is something called S100, and that stains the cells that typically surround or support the tumor cells. Here, by staining with S100, these stain what are called the sustanacular cells, you can better see this zelbellin or this ball-like characteristic of these tumors. S100 is very useful because primary tumors, that means where the tumors first grow, always have the S100. Although when the tumor spreads, the S100 or sustanacular cells typically don't go with the metastasis. So we can distinguish metastatic disease from primary disease based upon the absence or presence of S100 staining. And this is useful because sometimes it's hard to know whether or not a tumor that grows in the liver, for instance, is a primary tumor or a metastatic disease. The last histologic feature I'll highlight is staining for a protein that's called SDHB, or succinate dehydrogenase B. Tumors that retain SDHB are very unlikely to have a mutation in one of the SDH genes as the genetic basis for the tumor. However, if there's loss of SDHB staining, then this makes it much more likely that the tumor is part of a hereditary condition. And so these are now standard stainings and evaluations for pheochromocytoma and paraganglioma tumors. A very important note that I'd like to make is that genetic testing is recommended for any individual who has a pheochromocytoma or paraganglioma, and that is because these tumors are highly hereditary. Upwards, or approximately 35% of all pheochromocytomas and paragangliomas will have a genetic cause that runs in the family. And the likelihood of finding a genetic mutation varies depending upon the age at which the tumor develops. And there are a number of genes, and I'm not going to go through these today, that have been associated with hereditary pheochromocytoma and paraganglioma. But what's important to note that if you get one of these tumors in the first decade of life, you can see that it's very likely, 75% in this particular collection of data, that you have or that there is present a germline mutation that is a hereditary condition. And in this case, VHL is quite common in younger age. And what you'll note is that as you go older, the blue bar gets bigger, and this is sporadic. That means that there's no identifiable germline mutation. Importantly, even in folks that are 70, 80, or 90 years old, there is still almost a 15 to 20% likelihood of finding a germline mutation. This means that anyone with one of these tumors should have genetic testing, even though the likelihood goes down as you get older. Okay, why should one do genetic testing, or what are the implications? And that I'd like to highlight here. So first, if there's a genetic condition, you may be at risk for additional tumor types. And so knowing the underlying genetics is important for knowing what to look for, not only in the affected individual, but in the family members. Also, it gives information about the inheritance. So in the case for SDHD, it's very likely that if you get the tumor from your father, that you're more likely to develop tumors, whereas if you get it from your mother, inherit the gene mutation, it's less likely that you will develop tumors. So understanding the gene is helpful for understanding the risks to the next generation. It also tells us something about what the likelihood or risk of tumor metastasis is, and specifically for SDHB, this is an elevated risk. And then the final important point is that just because there's no family history doesn't mean that there's not a genetic cause. So for instance, for SDHA, a history of a tumor in the family is found in less than 10% of cases. So the summary here is that genetic testing is very important for understanding your individual and familial risks. And here I'd like to share an important paper that came from Rory Clifton-Bai's group by Dalia Davidoff. And what this work showed was that screening and knowing that someone has a genetic predisposition not only is helpful, but actually has consequences in terms of improving survival. So this is looking at individuals who were genetically tested and found to have a gene mutation, but weren't known to have any tumors. And so then because of the gene mutation, they had screening. And when you see these dots, that means screening identified a tumor. When you see the line, that means that screening was initiated, but no tumor was found. And the key points here are that when you initiate tumor screening early in life, frequently you don't find a tumor, but as you continue surveillance, eventually a tumor is identified, typically in the 20s or 30s. If you begin screening later in life, in the 30s and 40s, the first screening event often will find a tumor. So that is the reason that we want to start screening as young as possible. The other key point that I'd like to make here is that even in folks who approach the age of 70, they may have negative screening, and then in around 75, in this particular individual, a tumor was found. So the tumors can arise anytime in life. Screening is lifelong, but we'd like to initiate it as soon as possible. And then this is kind of the data that I think is really compelling for us to do this type of screening. In the dotted line, you're looking at people who are the family members of affected individuals, and the mutation was found because of another family member. And in the solid line, these are the folks that presented with the tumor and then were genetically identified. And what you can see is that survival is much better in folks who are the family members of affected individuals. That is, these people who underwent screening versus the individuals who didn't have the benefit of screening. And so there are a variety of guidelines available for screening, but the main conclusion here is that it's important to get genetic diagnosis, and this can improve survival, particularly in the case of SDHB as illustrated here. Okay, so now I'd like to transition to thinking about treatment. And treatment is highly nuanced and individualized, and this is kind of a generic approach. So each individual needs to consider their own care, their own specific case individually, but I'd like to share a framework for this discussion. So in general, if someone is identified to have a phéochromocytome or paraganglioma, our first option, and this is not true in some head and neck tumors, but generally, our first option is to go for curative surgery and to use alpha blockade if appropriate, if they're making metanephrine, if the tumor is secreting epinephrine or norepinephrine. Okay, if there's local recurrence and depends upon the extent of disease, oligometastatic means just a couple or one or two or very surgically amenable lesions, then we'd like to try to remove them if we can. I am not going to discuss today radiation or local or radiosurgery, although this is the second option for localized disease. What we'll focus on more is on how do we handle metastatic disease that's not surgically amenable. So in this first group are individuals who have a couple lesions that are slow growing and aren't really present, or maybe we're not sure how fast they're growing at. And so what we like to do initially is active surveillance. And that means imaging, get a sense of the pace of the disease, and whether or not it's progressing. Because we don't have any reliably curative therapies, the initiation of treatment should be delayed as long as the disease is relatively well controlled and is not heavily symptomatic. And as I'll discuss a little bit later, there is an idea of using medicines called somatostatin in order to slow the growth of these tumors. This is used in neuroendocrine tumors of the gastrointestinal tract or of the pancreas. It has not been proven to be useful in paraganglioma or phéochromocytoma, and that's why I have a question mark next in thinking about clinical trials, which I'll discuss again in a little bit. Another class of patients are folks with rapidly progressive disease or with high tumor burden. And in those individuals, our first choice is chemotherapy, we call CVD. And again, I'll discuss it. Unfortunately, almost no treatment modality in metastatic pheochromocytoma and paraganglioma really has randomized trial data to support it. Mostly this data are supported by collections of retrospective studies and meta-analyses. And so we're really lacking high quality data in this field. So CVD is first line, and then if there's progression after that, then I would say that individual should seek a clinical trial. The largest group is this slow to moderate progression with moderate to high tumor burden. And these folks are generally, our first approach is radionuclide therapy with something which I'll go into a little bit more detail called PRRT. Again, even though this is essentially a first-line treatment, that I'll share the data with you, it's relatively limited. If there's rapid progression after PRRT, then chemotherapy is usually initiated. However, if there's slow, moderate progression through PRRT, then there's second-line agents. Again, here, there's no clearly demonstrated agent that's the best agent to do next. So this is another area of question of where clinical trials would be quite useful. And we are learning more of what to do next. Okay, so I'll try to go into a little bit more depth about what we know and what are the evidence for various treatments. So I'll start with PRRT, which is currently one of our first-line agents for folks with moderately progressive disease, moderate tumor burden, and relatively slowly progressive disease. And I'd like to explain a little bit about what PRRT is. So this is based upon the idea that our paraganglioma or pheochromocytoma cells express high levels of the somatostatin receptor. And because the somatostatin receptor is relatively selective for these pheopara cells, we can find these tumor cells by taking a somatostatin-like peptide, which binds and finds the receptor, and then linking this somatostatin peptide to a chemical group that holds a radioactive agent. And this radioactive agent, depending upon its behavior, can either be used for imaging, for PET scanning, or it can be used therapeutically. And here is actually a structure showing the somatostatin-like peptide, and then this chelator group here, which can hold different types of radionuclide, either gallium for imaging or lutetium for therapy. This is a representative dotatate scan using the gallium, and you can see it does an excellent job of finding the tumor cells throughout the body. And so what we want to do is if we replace this gallium with a radioactive nuclide that can deliver radiation treatment, it does it in a relatively targeted way. However, it's important to note that some other organs, like the spleen, will also be hit. And so there are side effects, that this agent is not a perfect agent. Okay, so I'm going to share some representative data about what we know about PRRT and as well as somatostatin analog therapy. And again, this data are not randomized. This is a retrospective cohort study in which we're looking at disease, in this case, looking at first-line treatment with PRRT and what was the rate of disease control. And so essentially, it's 67 or roughly 67% of individuals get disease control when they're treated with PRRT as a first-line treatment. Interestingly, is that you get relatively similar disease control rates when it's used as a second-line agent. So even if you've received another treatment, PRRT with lutetium still is relatively effective. And then in this same study, they also looked at using what's called cold somatostatin. So there's no radionuclide here. This is just giving somatostatin. Since this is done in neuroendocrine tumors, it's also being tried in phéochromocytome and paraganglioma. And in this particular case, they had 6 patients, and they used the somatostatin analog treatment early on in disease, and they said, well, we stopped progression in 100% of these 6 patients. Other studies have done similar types of following and have not seen significant response rates. So it's really unclear whether or not using somatostatin early on in disease actually slows progression or not. That's why it's not currently considered to be standard care. If we jump back to looking at the PRRT and look how long it lasted for, whether or not it was a first-line agent or second-line agent, usually it's about 18 months before you see tumor progression as an expected median response time. Many individuals last much longer than that. It really depends upon specific tumor biology. We're working on finding ways to identify who's likely to be most responsive and who's likely to be less responsive. A lot of that has to do with how much of the radionuclide or how much somatostatin receptor the tumors have, how fast the tumor is progressing. I'm not going to go into those details today. In the case of the cold somatostatin analog, again, there weren't enough patients to really say what the response duration was. They estimated it somewhere between a year and 10 years. But like I said, it's unclear whether or not cold SSA treatment works at all. That's why there was a clinical trial that is currently not recruiting, but hopefully we'll see results from soon, which is whether or not using these drugs early on in disease is helpful or not. Okay, so again, I'm going to focus in on PRT and so again, repeat a little bit more about the data and then talk about what trials or what's coming down the road. So this is a meta-analysis where you're collecting as much data as you possibly can across multiple studies, and then looking at objective response. So actually what fraction of people had tumors change in size. And it's almost 25%, let's say, of folks that you can expect a little bit of tumor regression. And then if you look at overall response rate to lutetium or PRRT, it's more than 80%. So this meta-analysis, and these data are what have insinuated PRRT very early in the treatment algorithm for this moderate tumor burden individuals. And progression-free survival in this meta-analysis is roughly 20 to 30 months. It's very hard to figure out because different standards were used, and so that this is an estimate. And that's the median, roughly. And because this question of PRRT or lutetium has not been fully answered, there's an ongoing trial of testing whether or not this drug works and for how long. Of course, we're using it so much clinically, it's hard to recruit folks into the clinical trial, although we, of course, advocate for collecting this data so that we can understand if we're making the right decision for affected individuals. So I think what's one of the most exciting avenues in this field are what are the next generation radioactive materials. And so historically, for drugs like lutetium, we've relied on something called beta decay. So this is when the radioactive element undergoes decay and it releases an electron or a beta particle. And that beta particle is relatively high energy and it hits cells, and that damage that it does is what allows for a therapeutic response. However, if you look at the characteristics of these beta particles, they have actually a fairly long range, so they can hit cells that are a little further away from where the somatostatin receptor is, and this potentially has off-target effects. It also has the benefit of getting better tumor penetrance, so we're not sure if this range is helpful or hurtful. Although if we look at the amount of energy in this beta particle, it's relatively low when we compare it to a radioactive material that undergoes what's called alpha decay and kicks out a larger, heavier helium out. And then this range is much lower, has a range of only a few cells, and the energy is more than 100 times that of the electron. And so we're hoping is that this high energy and relatively restricted tissue penetrance will help us to get better targeted and more effective treatment. And so currently there are 2 clinical trials enrolling that are looking at these alpha particles. And what I really like about the one that's out of the NIH is that it's being used, it's enrolling as second line. So even if you've already had lutetium therapy, you're still able or eligible to try this second generation treatment. I think it's important, it's worth noting that in neuroendocrine tumors, what we've noticed is that if PRRT works the first time and then you see progression, in many cases, you can go back and use PRRT again. So in this case, you're being offered an alternative, which is to use an alpha particle or a second generation medicine. Okay. So what happens if there's progression through PRRT? What are our next treatment options? Historically, this has been a place where tyrosine kinase inhibitors or temozolomide have been used. Again, no real randomized data to answer whether or not these are the right questions, at least for temozolomide. Recently, we're getting randomized data for TKI inhibitors. And so what's known about temozolomide? Again, like I said, retrospective. And if we take everybody in this particular study, there's roughly a 13-month progression-free survival. We don't have survival data. And what's kind of interesting is that folks with SDHB or SDH gene mutations may be more responsive to this type of treatment than the non-SDH. So maybe temozolomide has a more specific role in SDH folks. And the reason is related to the expression of this temozolomide resistance gene, MGMT, or we think that's what it's related to, because this gets silenced in SDHB disease. There's also temozolomide as an alkylating agent cause DNA damage. It's been suggested that SDH tumors have a dysfunction in DNA repair, and so maybe they're more susceptible to drugs like temozolomide. Again, this is not known. However, this idea that SDH inhibits DNA repair has led to the following hypothesis. So the idea is that if you have very high succinate levels, which happens in SDH tumors, it impairs DNA repair. And then you can use a second agent called a PARP inhibitor, which is also an inhibitor of DNA repair. PARP inhibitors were developed for BRCA mutations and breast cancer, and they inhibit, as I said, DNA repair. And so when you combine an alkylating agent with an SDH gene mutation and a PARP inhibitor, the hope is that you can get very high levels of efficacy. And this comes out of mostly laboratory data with cell lines, and we are unsure whether or not this theory actually holds up in real tumors. And so currently there's an ongoing trial which is suspended, but I think is likely to continue. And it's using temozolomide alone in one arm and temozolomide plus PARP in the other arm. I think there's some concerns about whether or not this combination of medicines can be tolerated really well, although the hope is that there's good efficacy. Again, we don't know yet, and this clinical trial is paused, but may be continuing. Okay, the other medication option after progression through PRRT are tyrosine kinase inhibitors. And there's a number of drugs that are in this class. Most of them in some way target the blood vessel growth. And I'm using cabozantinib as a model or as a representative of this category because it's one of the stronger drugs. This is a study that came out of MD Anderson and was relatively recently published. And what you can see here is that actually there's not that many patients in the trial, 16 patients, but most patients either responded or had stable disease. And so there's a really relatively good treatment response. So the drug seems to do what it's supposed to do. However, when you look at median progression-free survival, that means how long the drug stays, the tumor doesn't grow for, it's about 16 months. So maybe not as long as we would hope for. And then, unfortunately, the overall survival rate wasn't dramatically improved. So I think these medicines are useful for controlling symptoms and for temporarily controlling growth. However, it's clear that these medicines are probably not likely to be the breakthrough drugs that we hope for. So they play a role, although I think these repurposed medicines, many of us were more optimistic that they would have better survival. So I think like I said, there's a variety of drugs in this class, and I just, because of time limitations, just chose one representative drug of the TKIs. Okay, I do want to share what little is known about CVD therapy, this chemotherapy. I think there's some important things to note. In this particular case, one thing that we should recognize is that occasionally CVD can have complete response. So it's rare, it's just a couple %, but folks with progressive advanced disease occasionally will have complete response. Overall, more than 50% of patients will have some response. And the duration of the response is 20 to 40 months median. This is an estimate. So I think there's a lot of hesitance about using classical chemotherapies, although it's worth noting that this is a relatively effective treatment for this disease. Although, as I said, these are retrospective data and we're lacking prospective randomized data. Recently, there's been a lot of attention on belzutifan, which was approved in May for the treatment of pheochromocytoma and paraganglioma. And I'd like to review a little bit of the underlying biology here. So belzutifan is what's called a HIF2 or hypoxia-induced factor 2 alpha inhibitor. This drug was developed because of the VHL disease. So in VHL tumors, this VHL protein is lost. And so this HIF2 alpha protein is always on, and we believe it drives tumorigenesis, particularly in the vascular growth of tumors or hemangioblastomas of VHL. So if, however, you have an SDHG mutation and potentially other forms of succinate other forms of pheochromocytoma paraganglioma, there's HIF2 activation because these metabolites can inhibit the function of inhibit HIF degradation, and so HIF2 is hyperactivated. So the thought is, can we use a drug that was developed for VHL in pheochromocytoma and paraganglioma? And I think this drug has been approved, but the data are unpublished, so we don't know really who is likely to be responsive. So what we do know so far is that there were 72 patients that were included, and they all had metastatic pheoparo, or that was local, not necessarily metastatic, but was described as either locally advanced or metastatic. The overall response rate is 26%. Again, we don't know what fraction of these 72 patients had a VHL mutation or had an SDH mutation, so we don't know who it is that's likely to respond at this point. The response duration was 20 months as a median, and they characterized how much blood pressure reduction by at least 50% occurred because of the production of norepinephrine and epinephrine. And so this is a good way of saying the medicine also helped to reduce drug usage or hypertensive usage. Now, there are known side effects. There's on-target effects. So most patients who are treated with belzutifan do develop anemia and then rarely have complications of hypoxia. So this is will be a chronically used medication. And so There's an ongoing clinical trial still looking at whether or not belzutifan is useful in pheopara. Again, because of its approved status, recruitment will probably be impaired a little bit, but I think it's really important to figure out who are the individuals who are likely to be responsive to this medication. We don't know that yet. How are we going to fit this into the treatment algorithm? I think different providers will do this differently. In my view, it'll probably slot in after PRRT. Again, belzutifan is generally pretty well tolerated, although we don't know who is likely to respond to it, so it's hard to know when to use it. And so probably it comes in at this later stage at this point. Okay, the last thing I'd like to highlight are that in general in pheopara, there's very low mutation rate. So the tumors, when you look at the DNA of these tumors, there's not a lot of changes. There's a low mutation burden. And so this means the immune system has a tough time recognizing these tumors generally. And so classical immune therapies are unlikely to be effective, and we have to think about different immune therapies or alternative strategies. And so here I'm raising two alternative strategies that are currently being trialed. One is taking T cells out of an individual and then engineering them to express a specific receptor that may be overexpressed on the tumors of someone's pheochromocytoma or paraganglioma. And the tumor can be tested to see whether or not this is the case. And if it is, then these cells can be taken out, modified, and then reintroduced. This, again, is, I think, an interesting study. We don't know what to expect, but I think modulating the immune system is probably in the future for many cancers, particularly metastatic disease, and this is a currently ongoing approach. A second alternative immune modulation study is one that targets this protein called ENPP, or the STING pathway. And what I like about this study is that it can target what's called the innate immune system. So it can take a tumor that the immune system is more or less ignoring and turn it from what we call cold into hot. And this, again, is in the right tumor type. So they have to have expressing the right types of protein in order to be amenable, potentially amenable, to this type of treatment. But I think this is, again, what I'd call an interesting potential clinical trial for folks who are kind of looking for something and don't have that many options. And I think engaging the immune system is one way which we might see a response and is worth considering. So with that, I'll kind of summarize the areas that I've gone over. I think the first and most important point is that we know relatively little about the biology of these tumors. Because of them being relatively rare, they're understudied. I think we're starting from a place that we need to learn more. As I've tried to illustrate, genetic evaluation plays a central role because of the role of screening in folks who are at risk or predisposed. In green, I'm going to highlight where there's potential for clinical trials. Standard treatments are definitely available, and there's currently trials that are looking at whether or not they are effective. And well, I think they are effective, but how effective they are is still being characterized. Perhaps the most exciting next generation of treatments, or closest next generation of treatments, are these trials with alpha decay, so higher energy. They're unproven frontier, but that's where things are moving quickly right now. Temozolomide as a second line treatment is likely to have a role, particularly in the SDH-related tumors, and whether or not the addition of PARP inhibitors is helpful or not still needs to be determined. I think the TKIs, they work, they have a particular role. I think it was hopeful that these repurposed medicines would do more than they do. But at least in some cases, they've been rigorously shown to have an effect, and we can have relatively reasonable expectations about how likely responses are. As I tried to highlight with the final trials, I think immunotherapy has a future here potentially, although we'll have to see whether or not we can engage the immune system with our newer approaches. And then finally, I think it's really important to recognize that disease-specific drugs are needed. In order to do this, we need to do fundamental research and find the unique targets of this particular disease. And so that's where I think we'll really be able to push treatment for metastatic para in the future. So with that, I'll thank you for listening and for joining the effort and care. We really hope to advance the field in metastatic pheochromocytoma and paraganglioma. There are active trials. We need more, and we need new pathways. So thank you for listening.